you regarding the predicting the surgical recovery and outcome in ERM as well as VMT surgeries. As we all know, 10 to 20% of the ERMs will have an unchanged or worse vision post surgery. So one need to predict what are the conditions which leads to poor visual outcome in these cases. The main and the relevant basic things one need to look at is one of the age of the patient. Lesser the age, better the visual acuity. The pseudophakic patients does well better than the phakic patients. Low baseline visual acuity, of course, a poor prognostic factor. Duration, especially if it is less than 1 year, the outcome will be better. Pre-op metamorphopsia score definitely tends to correlate with the post-op visual acuity. On OCT, look at the thickness of the fovea. The cystoid macular edema, if it is present, it is a poor prognostic factor. As we all know, the post-ERM peeling, there will be a ganglion cell reduction, which tends to correlate with the worst post-op visual acuity sometimes. INL thickness correlates with post-op visual acuity. The outer nuclear thickness doesn't have any correlation with the best corrected visual acuity. Does the pre-op macular contour contributes for the predicting the outcome? There are various pre-op macular contours will be there, either it's from a doom, flat or depressed type. The mean visual acuity gain was better seen with the dome shape preoperative macular contour than when compared to the flat or a depressed type. Early foveal pit recovery contour, definitely foveal pit restoration, early restoration correlates with best corrected visual acuity as well as the central foveal thickness and foveal avascular zone area. So it is one of the important predictive factors which helps in assessing the outcome in ERM surgery. There is an entity which has been described, which is known as in a Japanese word, which is called Tsukima. If you tend to say a clear-cut space between the ILM between the ERM and the ILM, these spaces, if it is present, it indicates a good prognostic factor and helps in a better surgical outcome. Another indices which have been described is what is known as inner retinal irregularity index, which is basically nothing but you measure the inner plexiform layer and the RP layer length of it. If you take the ratio of both these two, it gives the value of inner retinal irregularity index. This is a significant biomarker, the predicting factor, as the post-surgically, if you look at over a period of 6 months, the inner irregularity score increases and it tends to have a good outcome in these patients. Ectopic inner foveal layer, definitely it occurs due to the intraretinal gliosis and physical traction and leads to loss of visual acuity in many of the ERM patients. The thickness of the IFL, the ectopic inner foveal layer, basically it measured from the ONL to the ILM. So here, if you see an hyporeflective or hyporeflective band as indicated by this arrowhead, this indicates the ectopic inner foveal layer, which is associated with the poorer visual acuity gains depending upon the grade of ectopic inner foveal layers. There are 3 or 4 grades of ectopic, inner foveal layer has been described on a OCT based classification. 3 and 4 the grade tends to do poorly when compared to the grade 1 and grade 2. So stage 2, as I told, stage 2 ectopic inner foveal layers, they will have a better visual acuity outcomes compared to the stage 3 and stage 4. It is the presence of ectopic inner foveal layer is more important rather than the thickness of the ectopic inner foveal layers. Of course, one need to look at the outer retinal layers, that is ELM, IZ, the ellipsoid zone and interdigitation zone. Either they are assessed, look at it whether they are intact, whether there is a minor dehiscence or the disruptions or a major disruption, which tends to significantly correlate with the post-op visual acuity. Similarly, inner irregularity score, there is an outer irregularity score based upon the continuity or discontinuity of the outer retinal layers graded from grade 0 to 1 and 2. Like in this patient, they tend to have an intact all outer retinal layers. Here there is a disruption, so the reduced score, which tends to correlate with the visual acuity in ERM patients. If you look at the inner versus outer retinal deformation was relatively reversible post ERM removal, but outer retinal changes like cost line changes and other takes long time and may not recover sometimes post ERM surgery. The another entity which has been described is the photoreceptor deformation index. It is an indices measured at the center of the fovea and the paracentral area. You take a ratio of these things. This also tends to correlate very well with the post ERM surgery. On on-FOS OCT, the area of ERM, the contracted ERM is seen as a black zone, which is typically described as a zone. These are the radiating lines. This the size of the zone and other things, distinct plaque-like zone correlates with the visual acuity. Even the degree of stretched ILM lines adjacent to the ERM, if it is more, they tend to correlate more with the metamorphopsia score. So one need to look into these things on on-FOS OCT. The central bokeh abnormalities, it can be seen as nothing but a fovea cones thickening or detachment, which can be on various grades. There will be accumulation of widely formed materials like this, or presence of a subretinal fluid there. So these central bokeh abnormalities can be seen in any of the tractional maculopathies, including ERM. They tend to correlate inversely with ectopic inner foveal thickness, and cone bokeh abnormalities correlates with the worse visual function. The another entity which has been described is the disc fovea vascular distance. Basically, we need to measure the distance from the disc onto the fovea and from superior arcade to inferior arcade. This, if we can measure pre-operatively and post-operatively, we can calculate something known as tractional index of the membrane, which is nothing but a pre-operative distance baseline from the follow-up. So, if it is less than 1, it indicates significant membrane contraction. That's how you can assess the prognosis in many a patient. Of course, like in DME and any other conditions, drill, that is disorganized retinal inner layers, also serves as an important prognostic marker. The fundus autofluorescence, definitely yes. The baseline hypofluorescence sometimes associated with ellipsoid disruption. Hyperautofluorescence, there is a greater decrease in central foveal thickness without affecting the postoperative visual acuity. Octa definitely gives a clue in ERM, basically in looking at capillary distortions, changes in the FAZ. So basically looking at the vessel density, it's a positive prognostic factor if you look at these vessel densities, and they tend to correlate with post-op visual acuity as well as macular sensitivity. FAZ, as we know, there is in some cases post-ERM peel, there is a less expansion of the foveal avascular zone post-surgery. If such a scenario is seen, they tend to have a poor recovery, they tend to persist with metamorphopsia or anisoconia post-surgery. So one need to look at the FAZ size immediate post-op and the later post-op also. The another thing which has been described is due to distortion, you need to look at the linear vessel length as well as the branching distance once the contracture occurs. If you take a ratio of those two things also, which gives a predictive factor also. There are now with the choroid also seem to have certain changes in ERM, but the one significant factor is if you look at the satellus layer perfusion, which is a useful predictive marker in a patients with ERM. So another entity is, if you look at the choroidoscleral interface index, if you look at the choroid and scleral interface index, which also tends to correlate with visual acuity in many of the ERM patients. FFA definitely helps. If you see a vascular leakage in a patients with an ERM, they tend to have poor prognostic factors than in the cases which doesn't have a much leakage. So it is a very useful tool in helping the prediction of the. Then ILM dehiscence is associated with preoperative, postoperative increase in intraretinal thickness, and which is results in worse surgical outcome. Retinoschisis, because of the reducing the retinoschisis plays an important role in reducing tractional forces, hence helps in postoperative visual and structural outcomes are better in these patients. ERM with foveoschisis, the one thing is, if you see an ERM with foveoschisis, these patients tends to have a higher risk of postoperative macular edema, so one need to be careful in these patients with ERM with associated foveoschisis. PVD does not have a much impact on the postoperative anatomical or functional outcome. Intraoperative OCT, this thickness definitely helps in predicting the visual acuity. For if you got an access to intraoperative OCT, definitely yes. ERM, the eyes with shorter axial length associated with ERM tends to do poorly, especially in the initial post-operative period, but over a long term there is not much difference. If you see an AMD changes probably associated with ERM, they tend to have a poor prognosis. Eyes with the foveal herniation, what has been described with ERM, they also tends to do poorly in the immediate post-operative period. Multifocal ERG, no changes have been seen in amplitude, but one thing one should be careful is the amplitude and implicit time of positive peak significantly relates to the postoperative visual acuity. So the thing is, the age of the younger patients, lesser duration of symptoms, higher visual acuity at baseline, lower metamorphopsia score, and looking at the inner and outer retinal changes, and the absence of ectopic inner foveal layer, normal autofluorescence, and normal multifocal ERG, all these are good prognostic factors in ERM. The word about the VMT, as we know, many of the VMT patients have an anomalous PVD. So the type of attachment or an adhesion or attraction can have a outcome. For example, V or J shaped, what has been typically described, tends to have a different outcome. One have associated with a macular hole. One may get away with this. Smaller the VMT diameter and absent ERM sometimes leads to spontaneous vitreomacular traction release and a good outcome. and correlation has been there between the baseline visual acuity and resolution of traction. So one need to look at whether which cases progresses and which cases will have a spontaneous resolution. So you need to look into it. Thinner fovea baseline definitely has got a good prognostic factor with lower risk of progression to macular hole. So what are the poor prognostic factors in VMTs? One is if the disease duration is more than 6 months, the preoperative best corrected visual acuity is less than 20 by 200, preoperative thick central macular thickness, premacular fibrosis if associated with macular schisis and cystoid macular edema. Thank you. Thank you for your patient hearing.
Thank you, Sunil. Just to start on a couple of questions. Practically, when you look at your OCT, what do you think are the most important features that will help you detect a good functional and a good structural outcome?
Yeah, the one thing is if it is associated with the ectopic inner foveal layer, definitely it's a poor prognostic factor. The other thing is general factors on specifically since you asked for the OCT, inner retinal irregularity changes as well as the ectopic inner foveal are the two critical things, I think.
Yeah, that's for the poor outcome.
Yeah.
You had mentioned on Octa.
Yeah.
So, I mean, I have a doubt. Is there any role of the preoperative Octa? Because we know that it will be all bizarre, and the layers will be going.
Yeah, the many studies have variable results regarding the vessel density. The only parameter probably which may helps is the expansion and this thing of the FAZ, the foveal vascular pre and post peel.
Yeah, but even that will look irregular and
Definitely,
enlarged and all these things.
depends upon the scanning pattern and the artifacts also.
And one more thing, when you mention about ERM, lamellar macular hole,
Yeah.
it's always when to intervene and when not to intervene. Is there any OCT marker, other than vision and other things that will help decide surgery, the contour of the hole or anything?
The ERM with lamellar holes?
Yeah.
So probably probably I'll combine both the surgeries, ERM with ILM peeling in such cases. But if it is depends upon the degree of lamellar hole the associated with, because if there is not much changes anatomically, probably visual outcome may not be affected much in these patients. Ma'am, your thoughts on that?
A very nice presentation, Sunil, very crisp and to the point. Regarding George's question, there sometimes we get epiretinal membrane with a lot of macular edema that you think that, why is this membrane having so much macular edema? Probably that is a point where a careful Octa will tell you whether there was a vascular occlusion or something. You have to look beyond that central 3 millimeters, because if there is some evidence of non-perfusion or something in the periphery, it may give you a clue.
I just had a small doubt on. So one eye had a macular hole, other eye has a central bokeh abnormality, and the patient vision is 6/9. Will you operate on that patient? The other eye was lost to macular hole. The point, and I just want to know the parents.
Other is operated.
Other eye is not operated, but it's a large
Chronic-
CF1
chronic
meter.
hole.
Yeah, it's not going to improve at all. And this eye is 6/9 with central bokeh abnormality.
No, that all depends whether the patient is symptomatic.
Symptomatic 6/9, just symptomatic.
Yeah, 6/9 is not I mean, at least for me, 6/9 is not the criteria. But then if he's severe, I would give it a try, actually.
Yes, as told before, central bokeh abnormality is a severity, and whether patient is symptomatic, what is the presenting visual acuity, many criteria will fit into that.
So most of it, the patient is symptomatic, and we saw CBA, and the other eye has a macular hole which is non-repairable.
So symptomatic as in, is it a vision loss of 6/9 or is it a metamorphopsia?
She says that it is definitely reducing. I know, doctor, there is a difference between a couple of months back.
Okay, so if the patient demands it, probably, but there are reports of the CB abnormalities not changing over time.
Yeah, that's exactly
so
the point.
that is a point over there. So at 6/9, we still may have a role in convincing her to hold on for some time. That is not being so aggressive. But if there was metamorphopsia, that's a different story over there.
CBA, I mean, what I've seen normally is they do not complain of metamorphopsia, but definitely they complain of reduced vision from.
So the metamorphopsia component would be by the inner retinal changes more. So the inner retinal, from starting from the outer plexiform changes, are more aggressive, but that would be a indication to operate. more than 6/6 to 6/9 vision drop, because a 6/9 vision drop you may not gain after surgery is the point over there.
But what if you could prevent a macular hole? My point was, you create a macular hole and then operate it. Is that better, or trying not to? I just want Sir's
The
opinion as
CV
well.
abnormalities are a different pathogenesis than the macular hole formation. They're more of a slight pseudovitelliform deposition is more
Probably because of traction.
because of traction. Yeah.
And one more. Sorry. Yes. Go ahead, ma'am.
We very rarely see a macular hole having started from the central bouquet abnormality. I
Yeah.
think
So
we're
this is a
little,
real case scenario in my
yeah.
practice which I had. So that's why I just put up this
Give glasses and review after 3
3
months.
months. And one more thing, foveal schisis was associated with better prognosis. Sunil, foveal schisis was associated with better prognosis,
Yeah,
visual
but
prognosis.
that's what my thing is. If they're associated degree of one thing is the degree of schisis, the other thing is they tends to have a study shows that the post-operative thing is very critical, because many of such cases post ERM peel tends to have a more macular edema. That's what they've shown. But retinoschisis is more protective, overall diffuse retinoschisis when compared to the foveal schisis alone.